Hello and welcome to Dateline New Haven on WNHH, New Haven's home for community radio. I'm Paul Bass, your host, inviting you to look behind the headlines on the stories that make New Haven tick. Well, something's really interesting happening, not just in the world, but in New Haven, in the realm of artificial intelligence, AI, and healthcare. We just had our first of what's going to be an annual competition called the Health AI Championships, in which people are competing to get recognition and investment for groundbreaking applications for AI in healthcare. Now, before you freak out and run and think that like Elon Musk's brain chips are following you everywhere and you're never going to make another choice in your life, there's in fact an upside to this rapid change we're having technology now, which is that we're inventing new ways to take care of people. And we're going to hear about today. We have Dr. Lee Schwam is the Senior Vice President and Chief Digital Officer at Yale New Haven Health, and the Assistant Dean for Digital Strategy and Transformation. This is his baby. He pioneered this Health AI Championship, and one of the winners is with us today, too. She's a doctor who grew up around here, Richa Sharma, and she came up with a product that's going to help us figure out how to work with strokes. So welcome both of you today, and thank you so much for coming in.
Happy to be here, Paul.
So I'm going to ask you to go closer to the mic so you're almost touching it, but not quite. So Dr. Schwam, tell me how you came up with this idea and what happened on May 27th?
A lot of health systems are building programs to try to encourage physicians, clinicians, investigators to create artificial intelligence products that can improve healthcare delivery or healthcare operations. But they largely operate in silos. And one of the trends that I think has been a disappointing one is that with each of these progressive revolutions, the possibility that you could maybe take this idea, turn it into a company, that company could become the unicorn startup of your dreams, has started to silo off health systems from one another, and I think has started to reduce what had previously been a movement toward much more open source availability of code and ideas and much more collaborative kind of team science.
So just so I understand what you're saying people are everywhere trying to invent stuff. And now it's not just digital. It's not just that we can Zoom and have telemedicine. It's actually we're quickly developing technology that can crunch tons of information, analyze it supposedly, and I think we're getting there, and then help us do something with it a lot quicker and a lot better. And you're saying the way we do innovation in this country maybe is making it hard for people to share those ideas for the best results quickly because they're off on their own trying to raise the capital?
Or not necessarily on their own, but there's a desire to capture the value of that intellectual property and maybe keep it tucked inside until it's ready to fly.
So if I'm Dr. Sharma, I might be less, well, I'm not talking about you, of course, but if I'm someone like her who has some idea about how to use AI for strokes, I might not talk to other stroke developers or researchers in the field because I want to make sure I get the venture capital to get incredibly rich. And by the way, I'm not talking about you at all.
Yeah, or her employer. Right, her employer might say, well, we want to patent that, or we want to, don't share that yet. And so part of, I think, our responsibility as scientists and as members of the community is to create venues where we can share ideas, where we can promote a more collaborative approach to developing and implementing artificial intelligence. And I think I don't want to soft pedal the implementation part. When we invent a new drug, a new pill to control your cholesterol, we don't spend a lot of time thinking about the implementation, right? You get a prescription, you take the pill, you swallow a glass of water. We don't talk about that because the effectiveness doesn't vary largely with how you swallow the pill. But with AI, so much of its effectiveness can vary with how it is implemented. And even the fairness of the algorithms can vary based on how it is implemented. And so that has to be a really important part. And that's another great opportunity for collaboration because it's only when you see what all the different environments are where your algorithm might be used and understand how variable they are, that's actually what makes your product better.
And when you work for a nonprofit health system hospital, nonprofit university, there's still that idea that the universities do like to patent their, they like if you get someone like Richa who has an idea, the universities do want to be reaping some of the capital gains, right? So is there some limit there? Does the collaboration have to happen within your institution, or?
Part of it depends on how you're funded. Part of it depends on the nature of your relationship to your employer. But, the universities also provide a tremendous amount of support material support and resources.
Right, they want to get paid back. I realize that. But I realize, like mathematicians I know, they'll if they have a specific field, they will have 4 people from like Berkeley and
Mhm.
Michigan, and they'll work together. So tell me about. So you're trying to provoke collaboration through competition in the first AI championship. So what was the Health AI Championship, and what
So
happened?
we at Yale New Haven Health System and at the university have run competitions every year within our community for innovative ideas. But this year we worked with Senator Maroney in the state legislature, and we're allocated some state and federal funding to run a statewide championship. So now, not just within one organization, but we helped coordinate and manage a process where all 6 of the major health systems in Connecticut fielded ideas, reviewed
And did the
potential
ideas come
candidates.
just from people in Connecticut, or did they come from people
They
everywhere?
came from investigators or clinicians who were employed by one of those 6 health systems,
Okay.
and they could partner with others, but they needed to be anchored in a health system within
So
Connecticut.
54 people said, "I got," and what you win is not just recognition; you might get investment, right?
Absolutely. And you get the benefit of going through this process. You got coaching from some of our innovation leaders, and you also preparing for a competition makes you better.
So
Sharpens your
54 of
ideas.
these people applied. 12 were finalists. You had a sold out crowd. So where was this thing where you had the sold out crowd? I wish
We
could have
held
been
it on the Yale campus
there. Where?
in the Klein.
Oh, Klein
building.
Biotower,
Yeah.
where they just rebuilt it. Okay.
Yeah. In a lovely space.
How high up?
And sorry,
How high up were you?
we were.
Some of the top spots in New Haven.
No, I don't think so. We were like kind of second floor, but
Okay,
beautiful
you did.
view. No, and perfect space.
You're still up on the hill, yeah.
Yeah.
And so you had the 12 came, and how did it work at this event?
So each candidate, we built a whole symposium around this event. So the pitch was just one part. We had national leaders come and speak about the concepts, the framework for AI implementation in healthcare. We had people talking at the health system level about what does it take to implement AI in healthcare. And then we had the CEO of a company called Abridge, which is a extremely successful startup in the AI for clinical documentation space. It's called ambient clinical documentation. He talked about what it's like to try to enter the market and bring healthcare innovation from a startup. He's a practicing physician from.
And did the 12 finalists make presentations that day?
That day, all 12 had 5 minutes plus 2 minutes of questions from the judges. And they got up, they made their pitch. They got 2 minutes of questions, and at 7 minutes, a little bell rang, and you were yanked off the stage, and the next group came on.
And then it was after that the judges decided?
Yeah,
Same
and the
day?
judges went into a little huddle while we had another one of these presentations, and then the finalists were announced at the.
Well, that was a lot at stake, right? 100,000 for first place, 50,000 for second place, and then investors come. And we're talking about the Health AI Championship. We're really talking about the future of healthcare and artificial intelligence on Dateline New Haven on WNHH 103.5 FM. So, Dr. Isha Sharma, you were one of the winners. Congratulations.
Thank you.
50K isn't bad. Did you also get investors or in what you're doing?
I think we got something better. We got an alliance with the Yale New Haven Health.
If you don't
System.
mind coming closer to the mic.
I'm sorry. We actually got an alliance with the Yale New Haven Health System to start to work with their IT tech folks to be able to integrate our algorithm actually into the electronic health record.
Okay, so let's
which
tell
is what
people.
we were looking for.
So
from
you're
the
a stroke
onset.
doctor
I am.
at Yale New Haven.
Yes.
Are you also at the medical school?
Yes.
And what do you do there?
Duly appointed. So my role in the medical school is to provide education for all the medical students who come on service when I'm attending on the stroke service.
So you're helping the future stroke doctors.
Yes.
So what is it that you invented? This was along with you, Dr. Kevin Sheth, and Dr. Ho-Jun Lee. Ho-Jun Lee?
Yep. We are a tiny but mighty team.
Well,
So
all New Haven?
they are all at Yale.
All right,
absolutely.
hometown
Yep.
proud. Okay.
So as a stroke doctor, just to give a little bit of context, we often take care of patients in the hospital when they're having their dire stroke to figure out why they had that stroke. It's not only a single cause. Usually when you have a heart attack, it's usually atherosclerosis, but for a stroke, it can originate from multiple parts of the body: a clot in the heart, a plaque in the carotid artery of the neck, cancer. There are so many different possible causes of stroke. And while we have the patient captive in the hospital during their admission, we run a bunch of tests to figure out what the cause of the stroke is.
And again, if you don't mind just coming a little closer to the mic
Yeah.
so we can hear everything you're saying.
And the reason why that diagnosis of why the patient had a stroke is so critical is because we do have proven therapies, like Dr. Schwam said, to target those potential causes of stroke so that that patient doesn't have another stroke. The challenge is making that diagnosis. Once the diagnosis is made, we can very easily link those to proven evidence-based therapies that we can hopefully implement before the patient leaves the hospital to maximize the chance that they will not have another stroke.
What are some
And
examples?
just want to amplify. The reason it's important is that of those 5 major categories of causes of stroke, many of them have different treatments. So it's not just about the satisfaction of deciding exactly what the cause was. It's if it's this kind of problem, this treatment has the best chance.
And
of
what are the
reducing
5
risk.
causes?
So one is large artery atherosclerosis of the vessels of the head or
The
the
hardening
neck.
of the arteries. Plaque.
Exactly, plaque. A second is a source from the heart. So things such as atrial fibrillation can increase the patient's risk of having a
So
stroke.
what is that?
Irregular heart rhythm
Okay.
that many patients, particularly in their 80s and 90s, are very vulnerable to.
Things like the plaque or in the small vessels of the arteries of the brain. Other rare causes of stroke, such as a dissection or tear in the artery of the neck from things such as I've seen patients bird watching, roller coaster driving, lots of different esoteric causes of hyperextension of the neck can cause a tear in that blood vessel. And then ultimately the kind of catch-all bucket of a cryptogenic stroke. We did all the investigation to look for a stroke, and in the end, we have no known source.
So none of the above.
None of the above.
And what do we do about none of the above?
Good question. So,
Well, do you look at all your lifestyle, or do you look at genetic markers?
we and increasingly so, I think, as we get into precision medicine, I think we're going to be going down that path. But if the standard of care currently is if we don't know what causes a stroke, we do further diagnostics as an outpatient. We give them a standard treatment of an antiplatelet and a cholesterol medication. And we hope that something in the outpatient workup will be revealing.
So as a doctor trying to save lives, you are trying at first to figure out which of the 5 reasons someone has a stroke, and you invented a way using machine learning to make that easier to find it out. What did you figure out?
Yeah, and so I think the large challenge is really synthesizing an array of different diagnostic tests and using prior knowledge, using your clinical experience to assign a probability to one of those 5 categories.
So before you invented something, you'd be the doctor and say, tell me your history. You'd look at that thing we fill out 3 different times. It says, have you ever had this? Did your father have that? So you're looking at the history. You're looking what kind of episodes I've had. And you're looking at whatever you can figure out about while you're in the hospital.
And all those test results.
So now what are you able to do now? Is it just hyper speed? Is it more info you're able to pull together?
Couple of things. One is the sheer task of looking at all the different tests, all the different clinical narratives, what the patient has said when they first presented the hospital, and really kind of codifying each of those data points. The second is once we have those features categorized, we have an algorithm that can perform an inference to determine of the 5 possible etiologies, which one is most likely for this patient's phenotype.
And this is with a promise partly of LLMs, large language models, is that they not only can do a superhuman fast job of amassing a lot of and finding information, but it actually is making connections to those information to draw conclusions.
Exactly.
What could that do that you invented that you couldn't do?
I just want to add one other maybe metaphor here. It's not just looking at all the things. What it's really doing is studying how the experts look at that case and come up with an answer, and turning that into code that then lets a non-expert function like an expert.
And again, I'm not expert like you guys in AI. My understanding is that's exactly what people sometimes miss about AI. AI isn't a human brain that's coming out of nowhere with what we think this all fits together. It is drawing on the formulas you give them that human beings have come up with about how to analyze this data, and that it can just kind of do it faster and in more depth. Is that an accurate way of putting it?
So I think
and maybe finding connections you might not have seen by applying those principles.
Yes, I think there are really 2 major different categories of artificial intelligence that we have in our society today. The most well-developed are the predictive models. You take a whole bunch of baseline information and you correlate that with an outcome. So you get 5,000 patients, 2,000 had the thing, 3,000 didn't have the thing. You collect all the baseline information. You just say, learn from this and now predict for the next person what's going to happen.
So they're actually doing some reasoning you might not have done as a human, but you've kind of given them the roadmap of how to do the reasoning.
It's not
But to that point, so our major task was to bucket each of our patients into one of the non-cryptogenic stroke diagnoses. However, what we found is when we applied that algorithm to those that the experts deemed to be cryptogenic, we were able to reduce the rate of cryptogenic strokes.
So in other words, that none of the above suddenly became above by having. And how was it able to do that? What did you come up with so that that could happen?
So that's the beauty of it, is we trained it on patients who had non-cryptogenic strokes first. So it had a very well phenotyped cohort of patients to draw from.
It knew the pattern.
It knew
the patterns for the first four categories.
Exactly. And then we transferred that to that cohort of patients who were none of the above.
And then what was it able to do? So again,
I just want to say one other thing. Most patients with a cryptogenic, meaning a stroke of unknown cause, on January 1st, end up with a stroke of known cause later. In other words,
so
they don't remain cryptogenic forever.
So they get there faster. How? You still have the charts we filled out 5 times. You still have, the questionnaires. You have the charts of the 7 episodes in our lives and our 4 relatives. What is it really that this tool you've developed is able to do faster at a greater scale?
It characterizes the patterns of a patient's features that correlate with each of the diagnoses.
So might there be more inputs than normally would be there? Like, might there be some other feature from that data set of people in one of the other causes that might have to do with color blindness? I'm just throwing that out.
Absolutely.
Or an uncle who had a heart attack or something.
And so that's why we kept a very broad array of features, not just the traditional ones that us clinicians pay attention to. We used a very broad catch a net to catch clinical concepts that might not traditionally be associated with these diagnoses.
So more info, more info can go in.
And its ability to discern maybe nonlinear patterns was, I think, critical in being able to reduce.
And again,
that
this is the ignorant person here. So the 2 kinds of information that's different at scale is about the patient, but also about the patterns that a human being just looking at it can't absorb as much information as fast about all the factors.
And and the models don't offer explainability. So inherently, if you ask me, Dr. Schwam, what kind of stroke do you think I had, I will tell you my reasoning why. When you ask the model, its basically only answer can be because it looks like the other patients.
So are you still important as a human, doctor?
Yes.
Well,
are you gonna do you have to double check your work?
I will counter that point. I think we are getting more and more explainability. For example, from our model, we are able to extract the top 20 features in that patient's record that led the model to pick that diagnosis.
The model's explaining its reasoning.
It is. So
is
we're
it the
getting
same
closer
thing
and
as journalism,
closer.
where we still have to look at the at what articles it said it drew from to make sure it was a real article or a relevant article or publication that even exists? It's not a Soviet-friended disinformation.
We hallucination is still a problem that we
or even just imperfection.
Absolutely.
Like, in other words, like, do you double check
100%.
the reasoning too?
Absolutely.
So how did you come up with this? Like, how do you physically do this work?
Great question. So we used electronic health record data. So all of the data that's generated during the course of a patient's hospitalization from Massachusetts General Hospital, Yale, and Beth Israel Deaconess. So over 3,000 patients' text-based records. So their clinical narratives, their MRI brain scan reports, the CT scan reports, the echocardiograms of the heart reports, laboratory data, and we engineered over 2,000 features based on these texts. Once we did that, then we built 9 different individual classifier models to be able to predict what each of the patient's diagnoses were, with our gold standard being at least the consensus of 2 or more board-certified trained vascular neurologists impression of the diagnosis.
In other words, checking the work of the model.
So we were very rigorous in making sure we had a strong gold standard because, garbage in is garbage out when we really wanted to avoid that. So we don't routinely do brain biopsies of our patients who have an ischemic stroke. So unfortunately, we don't have that degree of a gold standard.
Is 3,000 a large data set?
That's a great question, and the answer varies by different machine learning tasks. For our test, we were able to have very, very good robustness of our performance, even with the 3,000.
Is it because of the quality? Because social science is notorious for, like, you interviewed 7 people and they're representative according to the chart of like all of America's 9 different tribes.
Luckily, we drew from 3 populations that were different. So, as you know, Yale New Haven serves a very diverse population that might be a little bit phenotypically distinct from the Mass General population and even from the Beth Israel population. So we had, I think, a good array of patients represented. And then when we assessed its performance in age, sex, and race demographics, it didn't change. The model's performance stayed steady.
What's the name of your tool?
So the classifier, the model is called Stroke Classifier. Now we're in the process of creating a more user interface friendly tool, which we're calling Polaris, that's powered by Stroke Classifier.
All right. So we're talking to Dr. Lee Schwam and Dr. Richa Sharma, who Dr. Sharma has invented with her colleagues a new tool to use AI to better diagnose the causes of strokes. And Dr. Schwam is our point person in New Haven at Yale New Haven for digital strategy and pioneering this annual new championship for health AI innovation. Just very briefly, Dr. Schwam, just what are some of the other inventions that were recognized? Just very briefly, what will they do to help us advance in AI?
Yeah, they were a really broad array, and they varied from a really great idea that hadn't been implemented yet to the other silver winner, which is a program that looks at an EKG, the picture of an EKG, not even the underlying electrical, like full digital data set. And from that can predict some very specific structural heart disease conditions that, again, more like what you said before, that the human eye just can't recognize. And it's not that different a model in the sense that you take a very large set of data, you find the condition of interest first, and then you train the model. This was the first EKG in the person who got that disease. This is the EKG in someone who didn't have that disease. Figure out the pattern. And I think that's a very, very exciting algorithm. And we are in the process of also starting to think about how would you take that idea and now start implementing it in the real world in a real health system, so that when you go to your doctor and you get a routine EKG because you're 55 and your father had heart disease, this algorithm is going to spit back out next to the EKG tracing a bunch of possible diagnoses. Where does that go?
And of course, that's only positive. The one concern I have as a patient, when I go for my annual checkup, if I'm in good health, that means my doctor wants me to check only 45,000 different little tests. That's something that could go wrong, because now that you have so much data, including an EKG you have to go for, she wasn't even worried about. Are we going to, as we age and our parts rust, are we going to be at doctors all the time because of that slight chance something could be a problem because we're going to overdiagnose
I think it's a really interesting question around.
It's all good. I'm not questioning.
Yeah,
it's good that we have better ways to find these things.
It's a really important question. As these tools get more powerful, we'll be able to do population level screening on tests that are already being done routinely that raise the possibility of other diagnoses.
I've already seen that happen, yeah.
And for diseases that are very common, those strategies are really effective. It's why we do screening colonoscopy, because colon cancer is common
and what a gift
and deadly.
That is.
And if you treat it early, you save lives.
Yeah.
So one of the litmus tests for this really should be, is it a condition that is common enough that screening for it is likely to identify people who really have it? And number two, is there something you can do about it?
Because we have seen all this corruption of the middle market insurance companies and the pharmacy benefit managers, where they're using this excuse that sometimes you're not even getting the test, but that's the Wall Street Journal.
Prior condition. Kind of thing.
But also that they're making so much money on having this stuff prescribed. But I'm off track here, because of course it's a total net positive that we can find diseases and cure them better. I just wonder if this is an example of what something that's lost in the AI discussion. It's not that bad things can happen by gaining more knowledge and having new technology, but that we as humans are still responsible for managing what we do with the information
Yes.
and how it affects our daily lives,
And-
which
I
really
think-
is not your guys' job, right?
Well,
No,
no. I think
no, it
Your
is.
guys' job is to
do-
figure out the discovery.
No.
I
Although
think
you're a
it's-
doctor, though,
It's
yeah.
our
Yes.
responsibility as clinicians as well. And what the model that we're putting forth is one of a co-pilot. So some a sort of a helper, a tool,
A doctor
almost
whisperer.
a doctor whisperer, or even if you an analogy would be like a GPS. Do I always listen to the GPS when I need to go to the supermarket? No, but sometimes it could be helpful. But I use my own discretion to be able to determine whether or not.
And that is so, I understand that so well, and I agree with you so much. My concern about GPS is my ability to instinctively understand my surroundings has eroded. Even though I don't like to use the GPS, it's a godsend.
We
when
call
you're
that
someplace
cognitive atrophy.
Yeah, are we going
Right.
to have a lot, or even doctors, not you, but are doctors going to have next generation have cognitive atrophy?
I think what we need, when I went to medical school, you had to memorize a lot of things. I'm not sure why, honestly, because there were books. But if I can look something up on the computer or on my phone at any time, anywhere, I don't need to memorize the formula. I need to understand why the formula is important. I need to know when I need to apply it.
when it
but
didn't work.
Yeah, when is it
And
when is it
Copilot, you
unlikely,
gotta learn how to
right, to be
analyze
effective,
it,
right?
yeah.
When is it inappropriate to apply that formula? But I think what we're going to see in medicine is an evolution from what I would call an apprenticeship model, where Dr. Sharma comes and she finds a doctor who is an expert, and she just apprentices herself to that doctor, learns how they do things, and then she just incorporates that in her practice, to more of what I would call like a knowledge partnership. We will have an AI partner helping us to care for patients, like we have an electronic health record partner who helps us care for. I don't remember what your allergies are, but the computer does. And when I pull up your chart, it tells me what your allergies are. And if I try to prescribe an antibiotic for you that you're allergic to, it won't let me. It'll tell me he has an allergy. I think what Dr. Sharma is referring to is this human in the loop. Right now in this country, appropriately, the human is responsible for every decision that gets implemented in the healthcare of a patient, whether or not a model recommended it. It will not be an acceptable excuse to say, the model said the stroke was caused by the heart, so I did what the model said. No, it will be, I took the model's opinion into consideration. Here's why I went with the model. Here's why I didn't go with the model.
And I wonder, Dr. Sharma, when you do this research, or Dr. Schwan, when you're looking at this more broadly, how much are we protecting against confirmation bias that will seep into these models based on the human being's work that is being fed into the algorithm?
That's a great question, and I think that's where explainability comes in hand, because the models that we're developing, we are purposely making sure that we can provide the clinician with some rationale for why that prediction makes sense, so that perhaps there are certain features of that patient that makes a cardioembolic stroke the most likely diagnosis, so that rationale can be incorporated into the clinician's judgment, the presence or absence of certain features when they make the diagnosis. And I do have to say that while overuse of AI might certainly is a consideration, it does really help level the field, because 5 out of 6 stroke patients are not taken care of by a stroke neurologist. And I have talked to, in the process of developing this, so many clinicians, non-stroke, non-neurologists, who are taking care of stroke patients and operating in a void of no expertise to help them.
Yeah.
So they envision having such a tool as an asset to provide them with the confidence, with the competency to be able to
So that
take
leads to
care
my
of
next
these
question
patients.
more
Wait, I
broadly.
just want to add one thing. This is like the argument about self-driving cars, right? Every time there's an accident with a self-driving car, it's on every news outlet in the country. But we know there are thousands of human instigated accidents probably every hour.
A lot of trips that don't crash.
Right. And I think the point is, it's compared to what? So in an ideal world, you would have an expert armed with AI making expert decisions. But the world we live in is one where many patients barely get adequate access.
And it's
to
truth that in a
expertise.
rural village, sometimes there might be a smart person who doesn't have credentials who will now be able to save lives. You know,
Yeah.
and I'm thinking about those 5 out of 6 people now who don't get access to a doctor with the expertise for strokes. So is the vision of healthcare here that more people will be able to get high quality healthcare because more people will be able to give it because we have this tool that will make it easier to do?
And to empower those clinicians who don't have that training.
And more broadly, how do you see in the field of strokes and more broadly in the field of medicine, what's AI going to make the field look like in 20 years? Are you optimistic about it, and how do you see it working?
I am optimistic. I think AI in many fields is an unknown, but I think AI in health will be beneficial because it will democratize specialized information so that patients can get the subspecialty care that they're currently extremely lacking in the U.S. You can imagine how steep that drop off is internationally and globally. So I think it can support a clinician. I think the opportunities of using multimodal different types of information, we are just cracking through in terms of biologic data, proteomic, genomic data to incorporate into these AI algorithms. And I think there's no ceiling.
So I'm guessing you're going to still be a doctor in 20 years. What's going to happen
I would hope so.
if I have a stroke and I see you in the hospital? Maybe I won't be seeing you. And then when I see you in your office, what's going to be different then from how it is today?
Well, my hope is that by the time you see me in the office, you will have a very well characterized treatment plan. That you know what your stroke was caused by. You're on the adequate secondary stroke prevention treatment, not just for the cause of the stroke, but for all the other risk factors that you might harbor that might not necessarily have caused that index.
And is a
stroke,
robot going to be giving me that initial intake where for the fourth time I fill out the questionnaire?
I hope that and this is what I'm trying to develop is that when I sit down and open the medical record in the clinic office, I will have a dashboard with all of this information.
I think that dashboard's kind of already there.
Not individualized to this extent.
All right, so it's just going to get better.
Absolutely.
And how about you more broadly, Dr. Sharma? What do you think?
You know, I was just reflecting on your question about, is this democratization fundamentally better or worse? And I think let's just look at the history of printing, right? In the Middle Ages, it took a monk a year to write a book, and very few people could read it, and almost no one could afford it. Then you got the printing press, and now suddenly you could mass produce books, but still it was pretty hard for people to afford them. Today, we don't even print. Most of the words that are consumed don't even get printed on a piece of paper.
And they're instantaneous.
And we have mass distribution. And not only can anyone in the world read what you've written, but anyone in the world can produce material to be read or listened to by others.
So the reason I'm optimistic about that is because if you write something good, a million more people can read it than they used to. The reason some people are pessimistic is because a terrorist or a deep fake evildoer will also do that.
Or just that, what if there's 1,000 poorly written things for every one well-written thing, right?
So we still need you two to go over the information.
So that's my point. I think we're at a precipice. We can let the tech leaders of the global tech leaders take charge and take over this healthcare space, or we as healthcare providers who are giving care to our patients and know exactly what that entails, we lead the charge. And I think that the latter model is how we get the most value and the highest quality.
Is that part of
AI.
the idea of the Health Art Championship? Is this empowering people like Dr. Sharma to have more of a say, or does it just help those tech leaders find them more easily?
It's raising the visibility of this new paradigm for care for health providers as well, not just for investors or the business community. It's also showcasing within the organization how possible it is. I mean, Dr. Sharma is not like working at Google or Amazon. She's first and foremost a clinician.
So you don't get as many good free lunches? Or do they still not have many? They still have those at Google? I don't know. So that kind of gets to your point about, for you, it wasn't just the money, and not even close, that you won with the three of you. But you said it's about I believe, how it's going to be incorporated, your work, into the health system at Yale. Can you tell me more about that? And is this an example of what you mean about having the people who do the work in the trenches and care about the use of the healthcare helping to steer its development?
Yeah. So I think for decades in clinical research, the field has generated so many prediction models, treatment models, and they've all been sort of siloed in publications. Wonderful. But they haven't been put into the hands of those who actually need it, the clinicians. And so my goal is that we can integrate it into our electronic health record system as a pilot and provide a sort of a user interface that the clinicians can start to alpha and beta test. Tell me, okay, this is helpful. This is not
So
helpful.
as a
I
result
need more
of your
explainability.
of your
And
victory
so
in this, Polaris is going to be used at Yale New Haven
that's the goal.
throughout the system.
So that's what we're working
And what
on right now.
about, do you have a private company developing it? Did you get investors?
So we are meeting with the American Heart Association Ventures Group. I guess they have their own VC to talk about whether they might be.
Well, I wish
interested.
you all the luck in the world on it. So that's what's next for Polaris. And what about for you? Are you also working on other kinds of innovations, or just going in every day and just saving people's lives?
That and I do have some funding for more stroke prevention research. So
Well, keep it up. Thank you for what you're
appreciate it.
doing. And before we leave, Dr. Schwab, tell me what's next for your efforts with what you started with the Health AI Championship. What's happened next with the event? What's happening next with the broader goals that you're pursuing?
One of the things that we're trying to do is really create a broad synthetic innovation community across the university and the health system to provide a better understanding of what are the most pressing problems that we have in the healthcare system right now, and what are the kinds of solutions that we're looking for as a way to help guide some of that innovation, so that people who aren't in healthcare know what they're aiming for. They're not just pulling back a bow and arrow and letting go. They actually have a target to aim at.
Well, good luck and keep it up. So I love learning about all this. I love learning the work specifically you're doing, and I love learning about all the big picture thinking you're doing and how you're putting it into practice at Yale New Haven. So thank you so much to Dr. Lee Schwam and Dr. Risha Sharma. Thanks to Harry Drost behind the controls as always. And thanks for listening, folks. We're going to take it out with the Afro-Semitic Experience performing I Wish I Knew How It'd Feel to Be Free from the Group C CD, A Plea for Peace. This is Paul Bass inviting you to fly free with us all day and all night long at WNHH New Haven's home for community radio.